Welcome to Medical Nutrition Therapy. Today we're going to talk about renal transplants and probably more relevantly chronic kidney disease. Here's an overview of the presentation. I am going to skip through quite a lot of the pathophysiology of chronic kidney disease because this is content that should have been covered elsewhere. Reminder about the anatomy of the kidney and the histology and architecture of the kidney. Notice that it's heavily perfused organ, gets a large arterial blood supply. It's a high pressure organ, meaning the uh, blood pressure is fairly elevated going into the renal artery, and the kidney is encapsulated, so it's under quite a bit of continuous pressure. This is the architecture of a nephron. Notice the functional unit of the nephron is the glomerulus, which is included in the Bowman's capsule. So the glomerulus is this arterial bundle. This is where the filtration occurs. A little more detail about the renal corpuscle and the filtration mechanism. Notice just this fine network, filtration network here between the arterial blood supply and the glomerular capillaries. Again, more detail. Important to review the functioning of the nephron and the functioning of the glomerulus if you are not fresh on its role in the overall transport of electrolytes and protein and fluid, reabsorption of protein and excretion primarily of sodium, reabsorption of some sodium and potassium. Even closer look, honing in. Then we get into chronic kidney disease. Chronic kidney disease is extremely common and extremely important. Hypertension is the number one risk factor for chronic kidney disease. It's not known to be reversible. In my clinical experience, it can be stabilized and some improvement can be made. Progression goes through stages. The stages will be defined momentarily, and certainly medical nutrition therapy is extremely important in the management of chronic kidney disease, as we'll discuss. So again, pathophysiology I think you've covered, but here's a list of conditions that can lead to chronic kidney disease. Again, hypertension is the most common. Hypertension combined with diabetes is the most common combination. These are some symptoms of people who have chronic kidney disease. Symptoms include fatigue, nausea, vomiting, pruritus or itching, and then later stage complications include seizures, confusion, and peripheral neuropathy. Notice these are pretty generalized symptoms. These are not specific to chronic kidney disease. These are symptoms common of many, many different conditions. The itching is probably the most pathognomonic for chronic kidney disease. Itching does occur because of the buildup of nitrogen in the tissues and the skin. But again, none of these are extremely sensitive. Chronic kidney disease is really diagnosed based on laboratory testing. So again, mechanisms of injury I think you've covered in pathophys. Endothelial function is one contributor to chronic kidney disease that I think is poorly appreciated. Again, remember you have a strong arterial blood supply. You have the glomerulus, glomeruli, which are primarily arterial bundles, and they are all lined with an endothelial lining. And as we talked about in cardiovascular disease, the endothelium is subject to not being able to really control. That is, the transport into the endothelium is not very well regulated, so it doesn't control what the cellular tissue of the endothelial layer is exposed to, and therefore very vulnerable. So endothelial dysfunction is a potent contributor to chronic kidney disease. Therefore, many of the therapies that we talked about with cardiovascular disease would also apply to chronic kidney disease. We've covered endothelial dysfunction in detail, and the dose response to sugar and fat we've discussed in detail. Advanced glycation end products again become relevant. Notably, advanced glycation end products are normally metabolized in the kidney. And here's the Maillard reaction we've discussed. We've discussed the impact of high advanced glycation end product meals compared to lower advanced glycation end product meals, and the impact that they have on flow-mediated dilation and blood flow. You can imagine if you have reduced flow-mediated dilation in the renal artery and you have somebody who is already hypertensive, then the blood pressure in the that the kidneys are subjected to can go even higher, thus confounding the damage already being done in an individual with hypertension. And this can occur again in the acute postprandial phase. So notably in the context of type 2 diabetes, diabetic kidney disease is very, very similar to chronic kidney disease. You get an overlapping of forces. You get the impact of hypertension. Many patients with diabetes are also hypertensive. And then you get the additional impact of the extra glycation due to continuous hyperglycemia. So this study is the United Kingdom prospective diabetes study, which evaluated the prevalence of, or incidence of various diabetes-related complications at varying degrees of glucose control. And after 10 years, there was an intensive controlled group and a kind of usual care control group. And at the end of 10 years, the intensive control group maintained a hemoglobin A1C that was approximately 1% lower than the other group and had a subsequent reduced risk of incident complications, 12% for any diabetes endpoint, 25% for microvascular endpoints, 21% for retinopathy, notably 33% for albuminuria at 12 years. So albuminuria is the excretion of albumin, of protein, into the urine, which is a hallmark sign of diabetic kidney disease and more advanced chronic kidney disease. And so 33%, that's obviously a large reduction, and what it illustrates is the strong association between blood glucose concentrations and renal complications. And in fact, clinical trials that have investigated whether intensive glucose control in people with diabetes reduces cardiovascular endpoints and cardiovascular mortality have largely failed. That is, aggressive glucose control does not, in the short term, reduce cardiovascular endpoints, but one exception is the onset of nephropathy, of protein-losing nephropathy, in which more intensive glucose control does seem to protect the individual. So again, the kidneys are very susceptible to hyperglycemia, likely because of this issue of glycation and glycation end products being metabolized in the kidney, and then those pathways just get overwhelmed by the hyperglycemia, and also because of just the arterial architecture of the glomerulus. And you can imagine any degree of endothelial dysfunction is going to impact the filtration and the function of those glomeruli. So do you need to tell the difference between diabetic kidney disease and chronic kidney disease? Not really. It's rarely even that important. Chronic kidney disease can be attributed to diabetes when macroalbuminuria is present. So this is defined by the degree of protein in the urine, which we can discuss. And then, or if microalbuminuria is present with diabetic retinopathy or in a patient with type 1 diabetes who has had it for longer than 10 years. These things mean that it's probably diabetic kidney disease. But in actual fact, if you see chronic kidney disease presented with somebody with diabetes, you know that their diabetes is contributing to the progression of their kidney disease unless their glucose is exquisitely controlled. So it's just a comparison between a normal capillary and a capillary with someone that has diabetes. The notable findings are really the thickness of this wall, of this capillary wall, and how, because of diabetes, because of the accumulation of glycation on the basement membrane in the glomerulus, this wall gets thicker, and thus filtration doesn't occur. Those fenestrated pores begin to close, and we don't see the normal filtration gaps. It becomes kind of dysfunctional, lots of fibrosis, etc. Thyroid disease can actually impact chronic kidney disease, and so low T3 is associated with numerous cardiovascular effects, including increased blood pressure, which can worsen chronic kidney disease. It can increase inflammation, it can increase endothelial dysfunction, can increase vascular resistance. So thyroid function hasn't been specifically studied very well in chronic kidney disease, but thyroid dysfunction has been studied in cardiovascular disease, and via the mechanisms listed here, it can have an impact in chronic kidney disease. So, clinically, someone who's really oriented around chronic kidney disease, a nephrologist, maybe even a primary care provider who's particularly knowledgeable. This would be a typical evaluation for somebody with long-standing hypertension. It's a little beyond the scope of the course, but just for your information. Also here we see some definitions of microalbuminuria. So the way that that albuminuria or proteinuria is diagnosed is through a urine test. It can be random, what we refer to as a spot, and we look at a spot albumin to creatinine ratio in the urine. And when it comes back on the labs, if that albumin to creatinine ratio is 30 to 300, we call that microalbuminuria. If it's greater than 300, that becomes macroalbuminuria or gross albuminuria. And albumin in the urine or albumin to creatinine in the urine less than 30 is considered okay. Here's the staging of chronic kidney disease. Notice here it's based on degree of reduction of glomerular filtration rate. Also, some labs do not even flag abnormalities in glomerular filtration rate until it drops less than 60. This is because if it's greater than 60, it's considered non-clinically significant. However, it is notable that if someone has their glomerular filtration rate flagged on a lab report and it is under 60, technically they are already at stage 3 chronic kidney disease. So they actually have been progressing, and so it's a little bit late, in my opinion, to intervene, but still better to intervene at stage 3 than not at all. Here's various labs once chronic kidney disease is diagnosed, including some with quite a bit of nutritional relevance, including homocysteine. There's a question here about testing MTHFR. This is because of the differential impact of different forms of folate on homocysteine and potentially the indication for different types of B12 on homocysteine for patients who do have MTHFR polymorphisms. This is not a clinical guideline. This is an emerging clinical trend to test MTHFR. There have been some studies specifically looking at stroke and whether homocysteine lowering in patients with MTHFR polymorphisms if stroke can be reduced if adequate folate doses are used. And there does seem to be an impact of polymorphism, of MTHFR polymorphisms, of risk of stroke and the impact of treating that with folate and B12. So we can talk about more of that later. I can try to post that article for you. C-reactive protein, measure of general inflammation, 25-hydroxycholecalciferol, of course, measure of vitamin D. Parathyroid hormone is very important to measure and directly related to vitamin D. Vitamin D deficiency often causes hyperparathyroidism. Many patients have been tested for parathyroid hormone, but not necessarily have been tested for their vitamin D status. Hemoglobin A1C if they have diabetes, and then nutritional assessments with relevance may include thiamine, zinc, omega-3 index, and certainly electrolytes, total protein, etc. Typical approaches, clinical approaches at different stages. And stage 1 and 2, again, prevention orientation through risk factor reduction. These would be all of the risk factors associated with cardiovascular disease and those that contribute to endothelial dysfunction, primarily blood pressure, smoking, but lipid lowering is also helpful. Cardiovascular friendly dietary pattern, again, due to shared mechanisms, evaluation of nutritional status, and intervention as needed. Stage 3 and 4 becomes important to evaluate for anemia. So we're thinking about iron, B12, folate. Synthetic erythropoietin, or EPO, is used as a kind of a rescue medication in patients with severe anemia. Unfortunately, the outcomes from using prescription EPO are not very good, and therefore my suggestion is to avoid it unless absolutely possible. Obviously, it's out of your scope of practice, but patients who have iron deficient anemia do respond to iron supplementation, and so again, it becomes important to actually have the anemia diagnosed properly. A lot of times providers they see anemia in patients who have chronic kidney disease, and they don't do their due diligence in the diagnosis. They say, oh, this is because of your chronic kidney disease, and they may not even do an iron panel, or they may not recognize the pattern of iron deficiency anemia, and therefore don't think to use iron supplements or injectable iron to treat it. And this is really unfortunate because it can really greatly improve the patient's quality of life and exercise tolerance and other things, and can also save them from from the need for prescription EPO, which is expensive and again does not improve outcomes. Vitamin D supplementation is commonly indicated because, again, the conversion from active or from less active to active vitamin D does occur in the kidney, and so when you begin to get chronic kidney disease, this conversion becomes abnormal, and normal vitamin D conversion is impaired. So this has an impact on electrolyte balance and bone health and all the other great things that vitamin D does, magnesium absorption, etc. General management, again, this is really a little bit beyond the scope, but blood pressure management, typically ACE inhibitors and angiotensin receptor blockers are used pharmacologically. Blood sugar management, exercise, nutritional management. Blood pressure target is less than 130/80. The evidence for lowering blood pressure to less than 130/80 compared to that lowering it less than 140/90 is not very compelling, but I think our understanding of the pathophysiology and some evidence that's available supports a lower blood pressure target. So I think 130/80 remains a good goal. Exercise, I'm not going to go through this slide in detail. You can pull the citation, and certainly I think you'll get the idea here that exercise is actually quite helpful in patients with chronic kidney disease. This study cites a Cochrane review that summarized 45 studies, which randomized a total of over 1,800 participants. The duration of the studies ranged from 2 to 18 months. The types of exercise that were included in the trials that were reviewed included cardiovascular training, mixed cardiovascular and resistance training, resistance-only training, and yoga. The intensity was low or high, it was really the whole range. And the results were consistent that regular physical activity significantly increases physical fitness for patients with chronic kidney disease, cardiovascular dimensions for people with kidney disease, some nutritional parameters including albumin, pre-albumin, and energy intake, and also improve health-related quality of life. So patients should be encouraged to exercise. Chronic kidney disease in late stage, patients go to dialysis. So we are summarizing hemodialysis as HD and peritoneal dialysis as PD. There's some figures in here that illustrate these procedures. Note that a lot of patients want to avoid dialysis, and for good reason. Dialysis is typically done at least 3 days a week, and it's approximately 4 hours per treatment. So obviously this is a huge time, has a huge impact on time, and is annoying, it's inconvenient. So here's the process of dialysis. That an arterial venous fistula is put in, and the blood is taken out. It's gone through here. It's dialyzed to this dialyzation membrane. The nitrogen is filtered out. Some electrolytes are filtered out, and the now filtered blood goes back through and is re-entered. There's another illustration. Peritoneal dialysis is similar, except it's done in the peritoneum. This is done a variety of different ways. It's far less common than hemodialysis, but sometimes hemodialysis isn't possible. So this is an illustration of peritoneal dialysis. When to start. So here's some main clinical indications for when people start. And notice that all of these are clinical. So main indications are pericarditis or pleuritis, progressive uremic encephalopathy, which is basically people become very confused. They can develop tremors. They can become clonic. That is, muscles can become contracted and won't relax. They get wrist or foot drop, or they can get seizures, which is an urgent indication of uremic poisoning. So uremia is, of course, nitrogen in the blood, and patients can also get bleeding episodes, fluid overload, hypertension retractable to antihypertensive. So hypertension that just will not respond to medications. Malnutrition, including cachexia. So because of the protein losses through the kidney, of course, the body does become or can become cachexic. That is, people can start breaking down their skeletal muscle protein in order to try to rebuild albumin in the bloodstream to maintain blood pressure. So malnutrition and cachexia, sarcopenia can be very common, especially certainly in late stage chronic kidney disease. And then if we have persistent metabolic abnormalities, again, refractory to treatment, including acidosis, increased blood potassium that won't respond, increased blood calcium or hypercalcemia, low blood calcium or elevated blood phosphates that we can't drop, then these are all potential indications for dialysis. There are different recommendations between the United States and Europe in terms of when is the best time to start dialysis. This question hasn't been subjected to very many randomized controlled trials, but one was called the IDEAL study, where they randomized about 800 patients with progressive chronic kidney disease to start dialysis with a GFR between 10 and 14 versus a GFR between 5 to 7. There was no difference in survival after about 4 years, no difference in events, dialysis complications, or infections. So the National Kidney Foundation guideline recommends beginning dialysis upon a GFR reaching 15. However, the European best practices guidelines suggest starting dialysis between 8 and 10. So obviously there's some difference. Europe tends to be a little more conservative. However, they also, a little bit more liberal, but they also tend to have better outcomes and lower costs. So important to consider that the indications for dialysis, again, are really clinical. That is, when patients start to have signs and symptoms suggestive of uremia, and therefore the GFR really isn't the best guide. If somebody has a GFR of 15, but they're actually doing fine, they don't have any symptoms, their electrolytes are balanced, they're not having confusion, fatigue, nausea, vomiting, pruritus, etc., then delaying their dialysis may be fine. Obviously, this isn't going to be your decision to make, but it may still be something that you can offer some counsel on with your patients. So chronic kidney disease, ultimate treatment is going to be renal transplantation. Again, this requires matching MHC antigens, finding a donor, and immunosuppressive medications given to prevent rejection. So this is lifelong on immunosuppressive medications if a donor can be found. So now medical nutrition therapy for chronic kidney disease. One of the most important things is prevention of malnutrition, especially protein energy malnutrition. And there's definitely a very delicate balance in severe chronic kidney disease between ensuring adequate protein intake and not overloading the kidney with protein. This can become even trickier with patients with diabetic kidney disease, because obviously, usually in diabetes, as we've talked, we're lowering the macronutrient ratio of carbohydrate. We want to lower blood sugar, so glycation is reduced. But yet we also have to be really careful of protein intake, and so now we're hopefully trying to moderate protein intake as well as carbohydrate intake, and it obviously that gets challenging. Nutritional diagnosis can be important, and then the intervention is really based on stage. So we're going to talk about a few things. We're going to go through this pretty quickly. One is general dietary patterns for prevention of endothelial dysfunction. We've covered a lot of this in cardiovascular disease, so I'm not going to spend a lot of extra time on this. Specific nutrient indications for chronic kidney disease, endothelial dysfunction, specific nutrients in chronic kidney disease, and then specific nutrients in dialysis. So here we go. So of course we've talked about nuts. We've talked about whey protein lowering blood sugar. We talked about vinegar potentially lowering blood sugar. So these are all strategies to reduce blood sugar and therefore reduce endothelial dysfunction, especially in our patients with diabetes. Mediterranean food or diet pyramid. We've talked about this in great detail, so I'm going to skip over these. PreDMed we've talked about in great detail. Summary of obviously fat quality, which I'm sure you've seen and support. Again, differences in carbohydrate quality. Reminding patients about the simple sugars in the beverages that they consume. Advanced glycation end products we've discussed. Some summary of some of the effects of low age diets. So nutritional considerations in chronic kidney disease, the summary there is, of course, all the things we've talked about for managing blood glucose abnormalities, preventing spikes in blood glucose, lowering the area under the postprandial glucose curve, and then following a general Mediterranean-style dietary pattern. Specific nutrients for endothelial dysfunction and cardiovascular disease. We discussed some studies on vitamin C. Here's the study on resveratrol again. Resveratrol plus GSE we've discussed. There's no human clinical trials on resveratrol. There's mechanistic rationale based on all of these reasons: increases in oxidative stress and activation of NF-kappa B, reductions in cytokines and chemokines, reduction in inflammation. These are all mechanisms that are involved with chronic kidney disease that resveratrol has some action on. So I think that there's strong rationale for using resveratrol in CKD, but again, hasn't been subject to clinical trials. We've talked about the endothelial response to omega-3 fatty acids. Not much effect. Mixed flavanols, asparagine, folic acid is beneficial, and so that's a repeat from cardiovascular disease. Now, what about specific nutrients for chronic kidney disease? There is a helpful resource that, again, the National Kidney Foundation has very good tables related to nutrition. So here's a list of some factors leading to malnutrition. So inadequate food intake due to social barriers, additional endocrine disorders associated with uremia, such as hyperparathyroidism, hyperglucagonemia. So this is an elevation in serum glucagon. It's not very common. And then resistance to insulin and insulin-like growth factor. The dialysis procedure itself causes protein losses due to amino acid removal. There's also an inflammatory response that can increase protein requirements. Loss of blood due to GI bleeding or frequent blood sampling, blood lost in a dialyzer and tubing. So this blood loss in dialyzer and tubing shouldn't be very high quantity. Frequent blood sampling shouldn't, again, result in very high quantity. But if you actually do have an iron deficiency anemia, then of course taking any blood can be problematic unless iron is replaced. And certainly GI bleeds can be very serious. So if that's the cause, then or if that's suspected, then the cause of the bleeding needs to be identified and stopped. And you can read those on your own. Again, identifying chronic kidney disease early is really very important, because then it gives you the greatest opportunity to focus on risk factor reductions and stabilize things. Stage 3 and 4, again, it's a good idea to look at the National Kidney Foundation guidelines. Adjusting dietary protein to 0.6 grams per kilogram body weight is a good rule of thumb. This is very important. So chronic kidney disease stage 3 and 4, this is where we start doing protein restriction, 0.3 grams per kilogram body weight. This is considered a minimum protein requirement this is a rule of thumb for maintaining muscle mass and serum protein levels. High protein does stress the kidney. It does cause increased demand for filtration, and it is problematic. I'll show you some evidence for that momentarily. We don't really know the optimal protein target, though, so more on that soon. Make sure kilocalories are adequate to prevent weight loss. Weight loss may be indicated for somebody that has diabetes, but you don't want to lose lean muscle mass. So this can be really challenging. We want calories to be adequate so that patients do not start metabolizing skeletal muscle to maintain their blood sugar, but at the same time we don't want to use so much protein that we create a filtration overload. I find that patients' hunger is a good indicator, and the foods that they're hungry for is a good indicator for the types of nutrients they need. That is, if a patient with chronic kidney disease gets an acute protein craving after dialysis or even before they have dialysis, then it could be an indication that they really need more. Now, that has to be tempered, because a lot of people, eat large amounts of protein-containing foods as animal products, and that's, obviously inflammatory, high saturated fat, other things. So you still want to counsel them on plant sources of protein, lean sources of protein, and again, keeping in mind their overall protein goals. In stage 5, diets can go much higher in protein. You have to then control intake of potassium, phosphorus, fluids, and sodium. And peritoneal dialysis, I doubt you'll encounter, but it is more liberalized, can be much higher in protein, and can also be much higher in sodium, potassium, and other fluids, but limiting phosphorus becomes important. I've never managed a patient with peritoneal dialysis, so that's a little bit out of my experience. Nutrients to monitor in both situations include protein, total calories, sodium, potassium, phosphorus, calcium, fluid, overall fluid balance, vitamins and minerals, as well as fiber intake. So this gives you some indications for nutrient recommendations for macronutrients and some minerals at different stages of chronic kidney disease. This is from the National Kidney Foundation. So it gives you some really no changes in stage 1 and 2. Or actually, I'm sorry. So this is all stages of chronic kidney disease, stages 1 through 4. Sodium less than 2.3 grams per day, total fat less than 30% of calories, saturated fat less than 10% of calories, cholesterol intake less than 200 milligrams per day, 50 to 60% of calories from carbohydrates, again, depending on diabetes status. And then here's some guidance for protein intake. So somebody with diabetes or without diabetes, approximately 1.4 grams per kilogram body weight. Stages 1 to 2, this drops to 0.6 to 0.8 if they have stage 3 to 4. If they have diabetes, protein, they actually recommend protein lower. Again, I think this is tricky depending upon the degree of blood glucose control, some phosphorus guidance, and also potassium guidance. Summary of nutritional considerations in chronic kidney disease. Again, protein, all of your minerals, vitamins, especially water-soluble vitamins, thiamine and riboflavin, polyunsaturated fatty acids, making sure that vitamin D status is adequate. And then there are some common nutritional excesses to be aware of. One is phosphate. Dietary restriction of phosphate may be necessary. Magnesium or calcium carbonate is also used for phosphate binding. Iron can become excess, but most often it becomes deficient. Vitamin A is not filtrated in dialysis, so vitamin A concentrations can become elevated, and melatonin is not filtered out in dialysis. So interestingly, a lot of times patients on dialysis end up with insomnia, but they actually have an excess physiological concentration of melatonin. So even though we do use melatonin for insomnia in some individuals, it's not indicated for patients who are on dialysis. Here's a good summary chart, depending upon the degree: chronic kidney disease, hemodialysis, peritoneal dialysis. Good summary chart for protein, energy, sodium, potassium, phosphorus, calcium, fluid, and vitamins and minerals, including which vitamins and minerals to emphasize. So this is a chart that talks about adjusted body weight for obese or underweight patients, and it gives you, this is basically related to fluid balance and learning how to calculate some fluid balance, but it also helps you adjust your protein requirements and calorie requirements for these individuals. Stage 5 chronic kidney disease. In terms of fat, follow the rules for chronic or for cardiovascular disease, recommending a cardiovascular disease-friendly dietary pattern for both. We do see changes in lipids with dialysis. Hemodialysis typically have normal LDLs, HDL, and triglycerides. Peritoneal dialysis, these lipid fractions can elevate. Most patients with chronic kidney disease do die from cardiovascular disease, so cardiovascular risk factor control is important. Stage 5 chronic kidney disease for protein. The recommendations for hemodialysis are to increase to 1.5 grams per kilogram. So for peritoneal dialysis, it's the same, except that during peritonitis, if there is peritonitis, then protein requirements are increased because of the inflammation. So adjusted edema-free body weight for obese and underweight patients. So this is where the previous slide, the slides are a little out of order, sorry about that, but this is where the adjusted body weight becomes important. Dietary protein in moderate to severe non-diabetic chronic kidney disease. So this is really important to be aware of. So this is, again, a Cochrane review where they took 10 high-quality studies where that they included at least a total of about 2,000 patients. About 1,000 of those had a reduced protein intake diet, and about 1,000 had a higher protein diet. And those in the low protein diet had a a reduced hazard ratio for needing to actually begin hemodialysis. And so these are patients, or excuse me, I actually think that this is mortality. The next slide will tell us the outcome, but this is a reduced hazard ratio for mortality related to their renal disease. And so they had about a 32% reduction in mortality with a low protein diet compared to a high protein diet. And so to avoid one renal death, 2 to 56 patients need to be treated with a low protein diet during 1 year. So 7 of the 10 studies measured a number needed to treat of less than 15 patients on a low protein diet. So here's some more data on this. So this is, again, we're looking at, these are hazard ratios, and we're looking at hazard ratios for renal death. The red diamonds, these are the studies where the low protein diet was between 0.3 to 0.6 grams of protein per kilogram per day. And the red triangles, these are the 0.6 grams per kilogram body weight per day versus a higher protein diet. So you can see that the 0.6 grams per day actually was pretty much the null. Like these are pretty much the same. The 0. And then one of the studies with the 0.6 showed a slightly reduced hazard ratio. This is probably about 0.8 or so. I think this is the dotted line is the pooled point estimate of the 0.68. Actually, I think 0.68 would be closer to here. So this is probably about 0.8. But notice that the individual studies of lower protein diets had even further reductions in their hazard ratio for renal death. So some suggestion in the evidence, actually a pretty strong suggestion in the evidence, that further protein restriction can be helpful. Talked a little bit about nutrients for endothelial dysfunction. This should probably be in that section. Again, talking about soy protein in diabetic kidney disease. So this is a randomized trial where they did soy protein supplemented diet, and to bring protein intake to 0.8 grams per kilogram body weight, containing 35% animal, 35% textured soy, 35% vegetable proteins. The comparator intervention was a 70% animal, 30% vegetable proteins. So you're comparing basically a 65% vegetable protein diet to a 70% animal protein diet. Outcomes at 4 years: the plant-based protein diet, including the soy supplemented diet, had a 23 milligrams per deciliter reduction in cholesterol. It had reductions in protein losses in the urine, and also a reduction in fasting glucose. So we don't know if this is really specific to soy protein, but it does support the use of a high vegetable protein diet. Apologies, I think that some of these got out of order. So this is looking at potassium balance. Potassium balance for patients with stage 5 on hemodialysis is 2 to 3 grams per day. And important to counsel in limiting high potassium foods. So the daily recommendations for potassium, as you know, are higher than this. So this is actually a potassium restriction. And that's because potassium is being recirculated in hemodialysis. Here's a summary for fluid and sodium, highly individualized based on residual urine output. So this would be in a dialysis center. You get a lot more experience with these issues working in a dialysis center. But these are some good rules of thumb. Phosphorus and calcium are very important in stage 5 chronic kidney disease. Hyperphosphatemia is very common when GFR gets between 20 and 30 or lower. Dietary restrictions recommended to 8 to 1,000 milligrams per day or less than 17 milligrams per kilogram ideal body weight. Phosphate binders we talked about include magnesium and calcium salts. Calcium losses are higher in chronic kidney disease due to impaired vitamin D metabolism. Monitoring serum calcium is important because hypercalcemia can result in cardiac arrhythmias and death. Recommendation is to limit to 2 grams from all sources. Be especially careful if patient is on active vitamin D3, so 1,25 dihydroxycholecalciferol or calcitriol, or calcitonin. Calcitonin is a hormone that increases calcium reabsorption. So sometimes calcitonin is used to help maintain bone health and help maintain serum calcium, but dietary calcium manipulation can cause hypercalcemia for patients in calcitonin if it goes too high. So notably, calcium is regulated by the action of at least three different hormones. It's regulated by parathyroid hormone as well as by calcitonin and vitamin D. So both parathyroid hormone and calcitonin can be increased when serum calcium drops, but usually it's maintained primarily through a balance of vitamin D and parathyroid hormone. Vitamin D doing most of the work. So calcium, active vitamin D, of course, absorbs calcium from the intestines. It helps absorb calcium reabsorption from the bones. Parathyroid hormone helps activate vitamin D and hydroxylates vitamin D in the kidney. So once again, helps with reabsorption of calcium. So the point of this is really that vitamin D and parathyroid hormone are very tightly regulated, or excuse me, very tightly related in calcium regulation. And when vitamin D concentration drops, parathyroid hormone increases is supposed to increase the activation of vitamin D, but when the activation of vitamin D is impaired, such as in chronic kidney disease, you can end up with hyperparathyroidism without necessarily seeing elevated vitamin D or adequate active vitamin D. So hyperparathyroid is common and is a direct consequence of hypovitaminosis D. Vitamin D3 does treat elevated parathyroid hormone if that's the cause. So that's really the bottom line, is that if hyperparathyroidism is indicated by labs and vitamin D hasn't been checked, it's very important to check vitamin D. Some studies of vitamin D have been done in chronic kidney disease. This was a clinical trial, stage 3 patients had stage 3 to 4 chronic kidney disease. The intervention was 2,000 IUs of vitamin D3 a day compared to placebo. Outcomes were no changes in insulin sensitivity, but there was an increase in glucose metabolism, suggesting an increase in renal metabolism and some improvement there. Another clinical trial took patients, only 52 patients on hemodialysis, and then some patients without hemodialysis. They were given 40,000 IUs of vitamin D3 per week for 8 weeks. Their outcomes showed an increase in vitamin D status, and then in the non-hemodialysis patients, the active vitamin D 125 increased. It lowered parathyroid hormone, and it lowered some biomarkers related to renal fibrosis, specifically FGF23. So this suggests that maybe in patients with hemodialysis, it might be too late to use vitamin D3 as a non-active form because you're probably not going to get much renal conversion due to the just progressive renal disease in those individuals. Whereas in patients who have not started hemodialysis, there's some benefit for vitamin D to be helpful. Active D2 seems to have similar effects on parathyroid function, no direct effect on. This is actually patients that had stage 3 to 4 chronic kidney disease who also had left ventricular hypertrophy, so they were also starting to demonstrate some signs of congestive heart failure. So the vitamin D did not impact their left ventricular mass or their diastolic function, but it did reduce their parathyroid hormone. So once again, showing this relationship between vitamin D and parathyroid. Nutritional therapy for chronic kidney disease, again, back to stage 5 chronic kidney disease and mineral supplementation. It's recommended to avoid magnesium-containing phosphate binders, antacids, and supplements unless patients have hyperphosphatemia. This is because we don't want to bind up too much phosphate. Phosphate's important, so if they have hyperphosphatemia, these magnesium-containing binders are indicated, but otherwise not. We talked about evaluating iron status. You can read through this again. And then zinc is a common deficiency. It can contribute to sarcopenia because it can reduce testosterone, can reduce immune status, so zinc replacement can be important, and evaluating zinc status in the blood can help identify if there's an insufficiency or deficiency. So vitamin supplementation in stage 5, we do want to replace deficiencies. You still want to meet daily requirements. Water-soluble vitamins, this is somewhat paradoxical because urine production is low. Therefore, water-soluble vitamins, including B vitamins, may actually need lower doses. But if patients are being dialyzed, then most B vitamins are lost during dialysis, and so may need to be replaced more frequently. But this is one thing where I would reduce the doses. I think using megadoses of B vitamins in somebody on dialysis is a bad idea. Avoid high doses of vitamin A because you do get an accumulation of fat-soluble vitamins with someone who's on dialysis. Vitamin C can precipitate kidney stones, again, because urine production and output is so impaired. And then avoiding high doses of other fat-soluble vitamins, including vitamin K. There's some mention here about may need to be on vitamin K if on antibiotics, and with all honesty, I don't remember the source of that bullet. So there is this issue about B vitamins. We'll talk about that. So there's this question of does B vitamin therapy slow progression of diabetic nephropathy and prevent vascular complications in diabetic kidney disease? So this was a study where the intervention was 2.5 milligrams per day of folic acid, 25 milligrams per day of vitamin B6, and 1 milligram of B12 times 3 years compared to placebo. The outcomes were annual measurement of plasma total homocysteine, serum folate, and serum B12. GFR actually decreased more in the B vitamin group, decreased by 16.5 milliliters per minute in the B vitamin group compared to 10.7 milliliters per minute in the placebo group. So B vitamins actually decreased more. And then also if we look at secondary outcomes including MI, stroke revascularization, and all-cause mortality, the B vitamin group actually had higher adverse outcomes than the placebo group, statistically significant, a p-value of 0.04. So borderline statistical significance, but a hazard ratio of twofold. So 2 times the risk of having an adverse cardiovascular endpoint after this long trial, 3 years of basically B vitamins. So there is this question about are all B vitamins created equal? This is a summary slide where they took patients with type 2 diabetes with A1Cs less than 8.5. They did have active diabetic kidney disease defined here, and the intervention was 300 milligrams of a synthetic form of thiamine known as benfotiamine. It was given as 300 milligrams PO 3 times a day times 12 weeks. They compared it to placebo. The outcome showed no decrease in 24-hour urinary albumin excretion. It did raise thiamine concentrations. However, from the other materials, you know that benfotiamine is an antagonist of advanced glycation end products. This is the trial where they gave benfotiamine to patients before that high advanced glycation end product meal, and it seemed to preserve flow-mediated dilation and reduce oxidative stress, etc. So I still think that there's a role for benfotiamine in chronic kidney disease, especially diabetic kidney disease for patients who will not reduce their AGE intake. But again, the clinical trials to date have been pretty small and fairly weak. This is a clinical trial of either polyunsaturated fatty acids, CoQ10, or the combination of polyunsaturated fatty acids plus CoQ10 compared to placebo. The outcome in both of the groups that got polyunsaturated fatty acids were a reduction in heart rate, a small reduction in blood pressure, no change in glomerular filtration rate, no change in albumin excretion, no change in lipids, no change in C-reactive protein, no added benefit of CoQ10. So there's a lot of great theories for why polyunsaturated fatty acids may be helpful in chronic kidney disease, including endothelial preservation, reduced inflammation, making more fluid cell membranes, etc. But in actual fact, other than a slight change in blood pressure, the findings were not very strong. One emerging therapy for chronic kidney disease is potentially the polyphenolic compound called fisetin. Fisetin is found in strawberries naturally, and it seems to increase the activity of the glyoxylase enzyme system. So glyoxylase is the endogenous anti-glycation enzyme system in our kidneys. It is a glutathione-dependent enzyme system. We do not have any human clinical trials of fisetin, but there has been an interesting study in rats that were actually I think it was mice. I think it was a mouse model for the development of type 1 diabetes, where when they were given fisetin, even though they had high blood sugar, they did not develop the complications of type 1 diabetes, and this was attributed to an increase in glyoxylase enzyme activity. Specific nutrients in dialysis. Vitamin C increased vitamin C concentrations. It decreased lipid peroxidation, decreased total cholesterol and LDL, 200 milligrams of vitamin C every other day. So notice the dose, 250 milligrams of vitamin C. This is not a gram or 3 grams or 5 grams. This is 250 milligrams. So this is less than what you would get in one of those tasty chewable wafers. and it's only every other day, so 250 milligrams every other day. So low dose, infrequent, not mega doses. CoQ10 in dialysis, 250 milligrams. Um, Sorry, this should say CoQ10. Error in the slide. Sorry about that. But 250 milligrams of CoQ10 for 6 months. The outcomes were reduced lipid peroxides, but no direct measures of progression or outcome in this particular study. So likely no major effect. Zinc in dialysis prevents protein catabolism, again, probably through increasing testosterone or stabilizing testosterone, and it reduced C-reactive protein. The dose here was 220 milligrams per day. Monounsaturated and polyunsaturated fats, comparing a diet that contained this amount daily compared to placebo. Outcome was an increase in body weight, a decrease in CRP, but no lipid changes. So increasing body weight in patients on hemodialysis is really important. So this is significant, and it just shows through manipulation of really the one variable, especially in diabetic kidney disease, where you're trying to keep carbs low and trying to keep protein to its recommended range based on the stage of chronic kidney disease. Actually doing a higher mono and polyunsaturated fat diet can have some beneficial impacts on body weight and inflammation. Alpha-lipoic acid in dialysis, 36 patients with end-stage renal disease on hemodialysis given 600 milligrams every day of alpha-lipoic acid compared to placebo. ALA reduced C-reactive protein, did not change oxidative stress, increased HDLs. So these are very peripheral biomarkers. I mean, these are important because, again, most patients with chronic kidney disease die of cardiovascular disease, so reducing CRP can be important. Increasing HDL can be important, but in terms of direct effect on GFR or preservation of renal function, anything like that, we don't have that. We don't have evidence to support that. Granted, these patients already have end-stage renal disease on hemodialysis, so this speaks to a potential role for alpha-lipoic acid earlier on in the progression of chronic kidney disease. Here's a couple quick slides on nutritional requirements for the post-transplant patient. Basically, energy needs are going to be increased after surgery 6 to 8 weeks. After 8 weeks, you follow the RDA. Carbohydrate glucose intolerance becomes common. Insulin or oral hypoglycemic agents may become warranted. Emphasizing high dietary fiber can help. Here's a summary of nutritional guidelines for kidney transplants. So a low-fat diet is helpful. Hypertension is common, so sodium restriction still is indicated. Potassium restriction acutely following the transplant, also important. Immunosuppressants are used to prevent rejection, so avoid grapefruit juice, pomegranate juice due to interactions with the metabolism of those medications. Cardiovascular disease still remains the leading cause of death, so cardiovascular-friendly diets, lipid lowering as needed. And there tends to be hypomagnesemia, so supplementation of magnesium can be important, again, with some attention to phosphate levels. Obesity, weight gain becomes very common, and obviously it can complicate hyperlipidemia and glucose intolerance, so emphasizing diet, behavior modification, exercise as you would normally, still indicated in these individuals. They do suffer from some of the same mineral imbalances. Osteoporosis and also altered vitamin D metabolism is still common. So again, measuring vitamin D, using active vitamin D as replacement when necessary. If they're on corticosteroids, they can actually end up with increased calcium excretion. So calcium losses due to the role of medications can be common. So supplementation with calcium and vitamin D is often indicated in the post-transplant patient. Phosphorus can actually become depleted, and certainly the same issues with potassium. So monitoring electrolytes, including phosphorus, as well as vitamin D status, becomes as important as ever in the post-transplant patient. Rejection, for patients who appear to be rejecting, they are put on higher doses of immunosuppressive therapies, and they do have an increased protein and kilocalorie requirement. So acute renal failure is defined as when the kidneys suddenly stop functioning or an abrupt cessation or reduction in glomerular filtration rate when nitrogen wastes accumulate. This is considered a stress or injury-induced hypercatabolic state. So um, there is rapid sarcopenia, rapid catabolism. So status declines rapidly, loss of lean body mass, toxicity related to the symptoms of um, of uremia, so of the buildup of nitrogen in the blood. So here's some causes for acute renal failure. Usually it's progressive chronic kidney disease, but also that can be exposure to renal toxins, uncontrolled glomerular nephritis due to infection that spreads and causes acute renal failure. Sjogren's syndrome is an autoimmune disease. Obstructions in the kidney can also cause acute renal failure. Clinical manifestations are azotemia, or uremia. So again, the increases in nitrogen in the blood. Um, Going to pause for just a second. Hello, this is Ryan. Yeah, hi. This is Ryan. Yeah, that's right. Yeah, that's right. Okay, I guess you don't know whether it'll be early in that window or late in that window. Okay, later in that window is actually much better for me. So I'll try to. I'll just wait your next call. I'll get over there as soon as I can. All right. Thanks a lot. Bye. Sorry for the interruption. If I stop the recording, I have to start all the way back at the beginning. So we were talking about acute renal failure. So clinical manifestations of acute renal failure, again, fluid and electrolyte disorders, the uremia or azotemia, muscle wasting, certainly electrolyte abnormalities, increases or decreases in potassium, magnesium, and phosphorus. They just have to be monitored frequently. And and then blood urea, nitrogen, and creatinine can be elevated even if their ratio is normal. So, and then some guidance on where to maintain blood urea, nitrogen. Again, this is a little beyond the scope of this course. Nutritional therapy for acute renal failure. So again, trace minerals and vitamins may develop trace mineral toxicity because, again, they're not filtered properly. Daily infusions are not recommended of trace minerals. Vitamin A, D, K, and C may need to be ingested. So A, D, and K, these are the fat solubles. Vitamin E also can be a problem, but doesn't usually cause toxicity. Too much A, D, and K can. Vitamin C, again, can cause precipitation of renal stones. Triglycerides can become elevated. So a lot of times these patients are going to be on enteral therapy or parenteral therapy, either on a TPN kind of food replacement, meal replacement product, or sometimes parenteral therapy. So these are going to, all of the ingredients are going to be adjusted depending upon the status of the blood and concentrations in the blood and whether or not elevated triglycerides and other things are happening. So this is something that's done, primarily in an inpatient center and with careful monitoring. Some guidelines on energy and protein, some guidelines on total kilocalories, again, guidance on ratios, again, about 60% carbs. Now we're at 20 to 35% fat, so obviously very low protein, 5 to 20% protein diet, so low protein. And again, TPN for greater than 5 days, usually restoring some fat as an emulsion. So again, this is an indication for TPN. Nephrotic syndrome, there's not much here. This is any condition in which proteins enter the urine is considered nephrotic syndrome because ideally, under normal function, the kidneys reabsorb all protein back into the blood. So here's a list of signs and symptoms. This is going to be something that you're probably going to see post-diagnosis. Treatment, this is the general treatment approach. From a nutritional therapy perspective, it's sodium restriction and diuretics to minimize any edema that occurs, control the intake of protein to 0.8 to 1.0 grams per kilogram per day. Soy or flaxseed based diets may be helpful. Protein supplementation has no benefit. So pretty standard plant-based moderate protein diet with sodium restriction to reduce the edema. Here's some recommendations. Nutritional assessment for the nephrotic syndrome, some things to consider. Basically, it's anthropometrics, watching fluid status, and looking at minerals carefully. Nephrolithiasis, this is kidney stone formation. Common kidney stones are oxalate stones, but you can also get other stones, including struvite stones, cysteine stones, hydroxyapatite stones, or uric acid. The risk factors are family history, hypercalcemia, hyperuricemia, hyperoxaluria, and low urine volume. Other causes are gout, excess intake of vitamin D, frequent urinary tract infections, urinary tract blockages, excess intake of vitamin C, and acidic metabolic states. They're asymptomatic until blockage occurs, and then it results in acute pain, blood in the urine, nausea, vomiting, pain with urination, urgency to urinate. Medical treatment. Most can pass with urine. It can be very painful to pass a stone, but in many cases they do pass normally. Medical procedures, if they're unable to pass, include extracorporeal shockwave lithotripsy is the most common. They can also be surgically removed. Need to increase fluid intake by 3 liters per day and in divided doses. No need to avoid dairy or calcium. It's important to determine the type of stone. Oxalate versus uric acid can be those are the two most common stones. Oxalate stones are the most common, but limiting oxalate intake to 50 to 60 milligrams per day can reduce the progression. Oxalates are found in vegetable foods, some vegetable foods as well as some animal foods. So, avoiding things like spinach and almonds can actually become important if somebody has an acute oxalate stone. And then alkalizing the diet. So these stones only precipitate in an acidic system. So alkalizing the diet by reducing protein intake, more plant foods, potassium citrate, and baking soda are also ways to prevent kidney stone formation. So nutritional therapy for the prevention of kidney stones. Here you go. And that's a wrap, folks.